This episode was recorded in Q4 2025. The information provided in this podcast is for educational and informational purposes only. The views and opinions expressed by hosts and their guests are their own and do not necessarily reflect those of the Irish College of GPs. By listening to this podcast, you acknowledge that no party is liable for any direct or indirect consequences resulting from the use of the information provided. More information can be found in the show notes or at irishcollegeofgps.ie.
Contraception is a really important part of, I suppose, considering EMA in the wider context of sexual and reproductive healthcare for women. And I would generally discuss contraception at visit 1, if the woman is amenable to do so. So visit 1 is a really good time to broach this because actually the majority of methods can be initiated at visit 2.
Hello and a very warm welcome to the GP podcast from the Irish College of GPs with me, Dr. John Marr. Today I'll be concluding my 2-part discussion on early medical abortion in the GP setting with Dr. Laura Cullen and Dr. Ciara McCarthy. If you haven't heard part 1 yet, you might like to pause here and listen to part 1, which is available now in the podcast feed. In today's show, Laura and Ciara discuss potential complications during or following EMA and how to diagnose and manage these, an approach to patients who may express ambivalence around their options, including appropriate signposting to aid decision-making, some contraceptive considerations, before wrapping up with some practical tips on starting an EMA service should this be of interest to you. And as a reminder, during this conversation, we're going to refer to the Irish College of GP's quick reference guide, Early Medical Abortion, Top 10 Tips for Non-Providing General Practitioners, which is available now to all members on the college website. I've included a link to the QRG along with the usual chapter markers and links to other relevant resources mentioned today in the show notes. Before we begin, just a quick reminder to record podcast listening to your PCSE portfolio as work-based learning, and remember each hour equates to 1 credit. And don't forget to vote for a future episode through our listener poll, which is available now on the PCS website. You'll see the poll on the lower left side of your PCSE portfolio homepage. And now on with today's show. We ended part 1 with a discussion of the 3-visit structure and how in-person reviews can be blended with virtual consultations to make EMA as accessible as possible to patients. I began part 2 by asking Laura to explain the notification aspect of the legislation following completion of termination of pregnancy.
So effectively, the notification is the legal requirement that once a patient has completed termination of pregnancy in your practice, that the Minister for Health needs to be informed within 28 days. It's a form that's available again from the college website and also from the Department of Health. And it's my practice that I tend to fill them at visit 2 and then hand them to a designated person at the desk who sends that notification off when visit 3 is completed. That's how I prefer to do it, but there are different ways of doing it, and some GPs I know maybe stack them up and send them off every fortnight. Really, that's your prerogative depending on how your practice works. I tend to have a stack of them on my desk printed. The other thing that I tend to do is I fill them in front of the patient so she's clear that what exactly is going on in that form, because this is a form that actually leaves the practice and goes somewhere else. And I reassure the woman while I'm doing it and show her what I put into the form, that there's no identifying details about her in it. The only identifying details in the form are about me, that the termination has happened on that day under my care in this county, and that's it. And most women are very reassured by that. And then that form, as I said, goes off to the Minister for Health and has to do so within 28 days. And we're regularly reminded of that by summary emails that we do receive through the Department of Health.
Thanks very much, Laura. And then, Ciara, you mentioned the three things that you're looking for really to confirm a successful early medical abortion being a satisfactory bleed, resolution of pregnancy symptoms, and the use of the low-sensitivity pregnancy test to confirm that the HCG levels have fallen sufficiently. So if I pop on my out-of-hours hat for a moment and, I haven't been involved in this patient's care, but they present to me on a Saturday evening, having taken the mifepristone and the misoprostol in the recent couple of days, but they haven't had what they were expecting in terms of a bleed. What should I be thinking, and what would my next steps be?
So I think what you're talking about is a patient who hasn't bled at all, or who's only had maybe a very light bleed, I suppose. So there's a few possibilities there. The first is that the medications haven't worked, and that the pregnancy it's an ongoing viable intrauterine pregnancy. The second is that it's an incomplete early medical abortion, where the pregnancy, I suppose, has ended, but not all of the contents of the pregnancy have evacuated the uterus. And then the third one, and I suppose the one that we really need maybe in our out of hours to have our radars up about, is the possibility of an ectopic pregnancy. So early medical abortion is not a treatment for ectopic pregnancies. We know ectopic pregnancy appears to occur at a lower rate in women undergoing early medical abortion than it does in the general population of women who present with pregnancy. But it still is, and it's obviously a very important thing that we need to be vigilant for. Firstly, in the context that we're discussing, which is women who don't bleed. But we also need to consider that when we're meeting women initially and thinking about, does this woman have a risk factor for ectopic pregnancy? Is she at higher risk? So obviously, if she's had an ectopic pregnancy before, if she's had PID, if she's had maybe previous tubal surgery like tubal ligation or salpingitis that she's needed surgery for, or if she's a woman who has conceived using artificial reproductive therapy, so IVF. There's a higher risk of ectopic pregnancy. And we do occasionally see women who've undergone IVF seeking abortion care. So that it's not unheard of. And in those women, I suppose you're seeing them before they've taken any medication. So for them, we need to mitigate the risk there. We need to reduce the risk. And we can do that in one of two ways. If the woman is 6 weeks pregnant or more, we can arrange for her to have a pelvic ultrasound done. And that will either confirm that the pregnancy is intrauterine or ectopic. Very straightforward. She either has treatment for her ectopic or she proceeds with EMA. If she's at a very early gestation, and many women are when they present, so under 6 weeks would be our kind of typical kind of line in the sand. Often the pregnancy is too small to be clearly visible on an ultrasound. So an ultrasound is only going to put us in a grey area of pregnancy of unknown location. So we need to consider how we can mitigate that risk. So the first is that we discuss it with the patient. We say, look, we can wait until you're 6 weeks and do an ultrasound and proceed then. But if she's made her mind up and she really wants to proceed, as soon as her legal 3-day wait is up, you can do what's called an enhanced follow-up protocol. And what that involves is monitoring the fall in HCG after she takes her medications. So you would take a baseline level when she comes for visit 2, but you would have to counsel her very carefully that she needs to come back after 48 hours after her misoprostol to have a second blood level taken, a second serum HCG level taken. And as I mentioned earlier, those HCG levels fall quite quickly. So we'd expect a drop of about 50% by 48 to 72 hours after misoprostol. So again, that confirms to us that the medications have worked, the pregnancy was intrauterine. If we don't get that fall, or if the HCG continues to rise, we are immediately referring to our local early pregnancy unit if she's asymptomatic. And the important thing to say is, and this again is really relevant for out of hours, is that if anybody presents either seeking abortion care or has undergone early medical abortion and presents with signs or symptoms of an ectopic pregnancy, they need, you're not waiting to refer them back to the GP provider. You're not waiting to send them to the early pregnancy unit. You are referring them to your local emergency department or emergency room in your maternity unit, depending on where you're working.
Okay, that's clear. And thanks for emphasising that, which of course could happen to any of us in the out of hours setting in particular. So that's our discussion on early medical abortion as a safe and effective treatment, which was point 1 in my top 10. In point 2, that reviews the fact that GPs, as we've already said, are not under an obligation to provide the service, but they must give the patient enough information to enable them to transfer to another doctor to get the treatment they want. And I think we've spent a good deal of time on that aspect already, so I might move past that. On to point 3. Signposting is simple through the My Options helpline, and we've already covered that. So I'm going to move again to point 4. The woman may express ambivalence about EMA. This does not mean the woman is unsure. just that it's a difficult decision for her. And Laura, could you flesh that out a little bit from your own clinical experience, please, in terms of the types of presentations you might see from women seeking EMA?
I've met lots of women over the years who have been very clear on their decision. And even when I've offered non-directive counselling to those women, they've refused because their decision is made and they're willing to proceed. I've met a fewer number of women who've been ambivalent about their decision. And what I think is important to know as medical practitioners is that we are not therefore in a position to take a hands-off approach and not proceed and tell the woman to come back to you whenever she's clearer, but that we, one, strongly encourage her maybe to get non-directive counselling either through My Options or other local providers that might be available to you, and that we tell her what the risks and benefits of the procedure is, as we would do in any other normal circumstance, and also tell her that her decision, if she wishes to proceed with the pregnancy, will be respected and she will be provided with care as in any other circumstance in that scenario. I also would go through the various steps of the procedure and offer her for me to certify the pregnancy if that's appropriate and fill the certification form if she's comfortable with that. But again, the overarching principle here is that she is reassured that it's her decision, that it will be respected regardless of what it is, and that she will receive the care that she wants, whether she chooses to proceed with the pregnancy or to end it.
Thank you. The next point here on the top 10 is point 5, which refers to the legislation underpinning termination of pregnancy and the timelines associated. And we've already been through that in terms of the 69 days or 9 weeks and 6-day window for EMA in general practice. So we've covered that, I think, to a good extent already. So I'll move on from that. And indeed, point 6, providing legal certification that the pregnancy is under 12 weeks gestation can be done by any doctor, providing they're satisfied with the estimation of gestational age. And we've already explained the importance of that and the potential usefulness of that for the patient, even if the provider, if the GP is not going to be a provider of EMA, they can certify at visit 1. We've been through the medications, which was point 7 in our top 10. And then point 8 is bleeding and pain are expected during EMA. These should be within certain parameters. Other complications can also occur, including treatment failure, incomplete abortion and infections, but these are rare. And Ciara, you've already given me an overview of those. So the next point here is another very, very useful one in terms of contraception. That's point 9. A discussion on contraception with a focus on long-acting reversible contraceptives is offered if appropriate. And the top 10 guideline gives an indication of the earliest time of initiation of appropriate contraception in the context of the medical termination. So, Ciara, could you give an overview of what contraception methods a GP can offer a patient who is undergoing EMA?
Yeah, so contraception is a really important part of, I suppose, considering EMA in the wider context of sexual and reproductive healthcare for women. And we would generally, or I would generally discuss contraception at visit 1, if the woman is amenable to do so. So it can often, they will tell you, I suppose, what they'd been using when they became pregnant. Did they have a contraceptive failure? That can be really important, using their chosen method. Some women are using no contraception and, they won't take you up on the discussion on contraception. And, that is ultimately their choice. But many women are really motivated to avoid another unplanned or crisis pregnancy. So visit 1 is a really good time to broach this, because actually the majority of methods can be initiated at visit 2. And that's really important, because actually fertility returns really quickly after early medical abortion. Women can ovulate as early as 8 days post-EMA. So if we consider that visit 3 typically takes place 2 weeks after visit 2, we've actually potentially, if we don't go there with contraception until visit 3, the woman could potentially be pregnant again. So it is really important that you talk about it at visit 1. And if the woman is amenable, all methods actually, except intrauterine devices, so except your copper coils and your leave-in or gastral intrauterine devices, can be initiated at visit 2. And they will be effective immediately if they're started on the day that misoprostol is given. There was a kind of a theoretical concern that giving, because mifepristone is a progesterone antagonist, that giving progesterone only or contraceptives containing progestogens could either interfere with mifepristone or it could interfere with the progestogens, but that doesn't seem to be founded in practice, and it certainly isn't recommended to delay initiating them. But obviously, with fitting an intrauterine device, you need to be certain that the procedure has been complete. So the earliest time an intrauterine device could be fitted is at visit 3, 2 weeks after the medications are given. And again, if a woman expresses a preference for a coil, you might want to consider whether she needs a short bridging contraception with a pill of some kind, or perhaps a single shot of medroxyprogesterone acetate, just to reduce her risk of a kind of an interval pregnancy while she's awaiting her coil.
It was really interesting to read that contraception, such as the progesterone-only pill, are appropriate to give at visit 2. And I do recall my own training and this idea of the potential for that to be an ineffective form of contraception. So it can be a really useful option, even, I guess, to buy some time, as it were, for a woman who's considering her options, that the progesterone only or progesterone containing medications are also appropriate options. So really, as you said, everything outside of the intrauterine devices are in play at visit 2, which is really helpful, I think. So thanks for that.
Unfortunately, I have come across a couple of examples where women have come back to me following an EMA immediately pregnant. And just to state that that's extremely distressing for the woman. So it does happen. And since then, I have always kept a stack of Depo-Provera's in my practice that I've strongly advised women to consider if they're not going to take a prescription for another form of contraception. And they're just there, so you can use it straight away, as Ciara has said. It's particularly important in cases where a patient might be vulnerable, or certainly in circumstances where you might be concerned that coercion is an issue, that you offer a patient something which will potentially keep her safe and buy her time to make her decision about more appropriate contraception from her perspective.
Okay, that's really a really excellent example, Laura, and a great tip in terms of having supplies to hand if possible for scenarios such as those you outline. And then the final point in the top 10 is point 10, the process of EMA is complete when a specific pregnancy test is negative. And we've already discussed that, and that it's usually approximately 2 weeks after taking the medication, and the importance of not using a standard pregnancy test for that purpose. So we've gone through the top 10. From my own perspective, I found this conversation so far really, really helpful in giving me a lot of very useful information to be better able and competent and confident in dealing with women who present with a request or who are considering an early medical abortion, whether I'm going to provide that service or not. There's lots for every GP, I think, to consider and to gain from this conversation. So again, thanks so much to you both. Is there anything that you'd like to add from that top 10, Ciara or Laura, before I ask you about how a GP interested in upskilling in this area might go about it and ultimately potentially seek a contract from the HSE? Anything else from the top 10 or from the clinical matters that you'd like to add?
Just the other things that women might present to out of hours with as well, Laura. I suppose we've really covered ectopic really well, but I suppose the other things would be hemorrhage. So we know excessive bleeding after early medical abortion is very rare, and the need for blood transfusion is well under 1%. In fact, it's only 1 to 2 per 1,000 women. So excess bleeding is rare, but you are watching out for women, and they'll be told to, seek medical assistance if they're soaking 2 maxi pads or more an hour for 2 hours or more. or if they feel, that their bleeding is heavy and they feel unwell. Again, they feel lightheaded, they feel faint, they feel unwell. So they may present. And I suppose for women presenting with heavy bleeding, it's no different to post EMA. It's no different to a woman who's undergoing a spontaneous miscarriage who presents with heavy bleeding. You're going to manage, in terms of your ABCD, you're going to contact your emergency services, you're going to arrange for an ambulance transfer if required, put in a line, give fluids, you may be able to reassure them, you may be able to contact my options and outline what's going on, and they may be able to tell you whether this woman needs to go to secondary care or not. Infection then would be the other ones. So an endometritis, which can happen. Again, it is rare. Risk is less than 1%, but it is more common in women who have an incomplete EMA, and they may present with bleeding that had been getting lighter and becomes heavier, bleeding that's foul smelling, maybe worsening lower abdominal pain, or obviously fever or systemic upset. And again, what you do with women, I suppose, will depend to some extent on if they're unwell. They obviously, if they're systemically unwell, they obviously need an emergency department referral or emergency maternity unit referral. And again, if they're systemically well, they do still probably need antibiotics. And whether you prescribe them or not in the out of hours setting is probably dependent on your level of comfort with doing that. You may feel more comfortable referring them into the maternity unit, and that is, into the emergency room. And that's absolutely fine. But we do, I suppose, during Monday to Friday, providers do manage women who have mild infection and are well in the community. But again, that is dependent on the individual provider's level of comfort. So I suppose it's just to reassure people in the out of hours settings. A lot of this is what you would do for any woman who is experiencing a spontaneous miscarriage, who presents with what might be a complication of that. The management for a complication of EMA is largely the same.
From recollection, antibioticprescribing.ie is a very good resource if you do suspect somebody who's systemically well, and that you feel they are fit for management in the community. But I believe even antibioticprescribing.ie specifies having a low threshold for referral to the emergency department. So
exactly. And obviously a careful follow-up plan as well, very careful safety netting with the individual woman as well.
Okay, well, thanks to you both for adding those additional things to look out for, either in the daytime practice or in the out of hours, because these are things that can catch any of us out, and it's great to be forearmed with some of this information and knowledge. So, like I said, I've found this conversation really useful for my own practice. For those listeners who may be interested in taking the next steps towards becoming eligible to take up a HSE contract for EMA, Ciara, what are the steps that must be taken?
So I suppose there's kind of two things to consider. There's the kind of, I suppose, the administrative part of the setup, and then there's the education and training part of becoming an EMA provider. And with regards to kind of training, we would recommend that everybody would do one of the Irish College of GPs training sessions. They do run in person once or twice a year, but if you are looking to provide, and there isn't one upcoming, there are a number of online resources that can suffice for you in the interim. They're housed on the ICGP's education platform, so it's icgpeducation.ie, and you might link to that as well. But there's two main resources on the ICGP education platform. The first is a blended learning resource that we developed for GP trainees, but is available to all ICGP members. And it walks through a lot of what we've discussed today, really. It kind of walks through the basis underpinning the kind of legal and clinical framework that underpins EMA provision in general practice in Ireland, and then walks through, I suppose, visits 1, 2 and 3, and what one needs to discuss and ensure at each visit to make sure that a woman is receiving kind of comprehensive and safe care in line with our legislation. And then there are some video recordings that are from a training update that are also available on the ICGP's education platform, and they are similar to what we would cover in the first half of our in-person updates. So they're again a really good grounding in terms of covering what you need to know about visit 1, 2 and 3, any complications, and again your legal and ethical obligations. And then you've mentioned the top 10 tips for non-providers, which is one of our quick reference guides or GP updates. But there's also a second quick reference guide called Clinical Support for Termination of Pregnancy in General Practice, and that is a phenomenally comprehensive document that covers, is more aimed at GP providers, and again covers in more detail the visits, what we need to consider, and again kind of grounds all of that in the HSE's model of care for termination of pregnancy. So I might hand over to Laura then to discuss the kind of practice aspects of it, if that's okay.
Yeah, so having been through this process myself, you can sometimes feel like a bit of a ship on the sea at night, and you're not sure where to start exactly. But I'm going to give you the biggest practice hack ever. Appendix 2 of the Early Medical Abortion QRG that was written by the fantastic doctors Trish Horgan and Ken Hart, who are both practicing in Cork, basically gives you a list with tick boxes, and everybody loves a tick box, that you can go through to help you set up your practice. And it goes through things as basic as, have you completed some training, which we've already discussed. But then there's more practice-based elements which are actually quite important. So they suggest that you maybe consider a values and attitudes exercise with staff. And certainly I did this a long time ago now, but during a practice meeting, I said to the staff in a very informal manner that I was considering starting the service in the practice, and I left the door open for them to come to me to discuss their opinions on the matter. I said they could either discuss them in public, or I was happy to talk to them in private, and that was really, really, really useful. I also do it with any new staff that are coming into the practice to let them know that I do respect their opinions. And that allows you basically to proceed with the service being mindful of people's position. And then after that, really, it's more practical things like reaching out to other local providers and having a chat about their experiences, linking in with organisations such as the START organisation, who have a fantastic WhatsApp group. And unfortunately, I didn't come to that until later years, but they are just phenomenal. They give nearly immediate peer support and advice for tricky scenarios via WhatsApp. I think the next thing would also to be important is to be clear on referral pathways. We discussed that earlier about where you would send somebody for scanning or who's responsible for EMA care in your local secondary care unit. And then moving on to things like what lab are you going to send blood tests to for things like serum beta HCG, making sure that you're clear on what pharmacists locally will be ordering in medications for you to dispense, setting up templates on your computer system to make everything just more seamless. And where do you order things like information leaflets and low sensitivity pregnancy tests, and making sure you have those things in the practice before you get started. Then you have to consider things like who's going to take care of your patients while you're maybe on annual leave, or if you can't provide visit 2 for a patient because it's on a day when you're not normally in the practice, or you might be teaching or something. And is that going to be another colleague in the practice, or do you need to reach out to a local provider and see if there's some mutual agreement that you can come to whereby you see their patients if they can't, and vice versa? As I've suggested already, having supplies of things like DMPA or Depo-Provera in the practice is important from my perspective. And in some scenarios, having supplies of LARCs like Marina or Kylena or copper coils, should the patient opt to proceed with that at visit 3, and if you're in a position to provide it. I can't speak highly enough of that checklist. It's just brilliant. I would strongly recommend that you print a copy, go down to your practice manager, have the chats, and just get the ball rolling. And it will literally give you every step-by-step thing you need to do to get up and going. And I wish there was one of those tick box lists for every service that my practice provides. In fact, there might be a little idea. Thanks.
Wow, Laura, that's fantastic. I feel like you've saved me many and many others, I'm sure, migraines in terms of your own understanding and past experience with setting up such a service. And if I could just go back a little bit with you, and apologies for my ignorance, Laura, but you mentioned the START group. Is that START? And how would a GP go about making contact with them?
I'm actually going to hand over to Ciara for this because she's been involved with START for a very long time, and she's certainly much more au fait with how it all works. But just to say again that I found them phenomenal in the last few years that I've been involved. And if it's okay with you, Ciara, I'll let you take over.
Absolutely, Laura. So for anyone who's not familiar with START, START stands for the Southern Task Force on Abortion and Reproductive Topics. And this is a group that was formed in Cork following repeal of the Eighth Amendment. So in Cork, we had a group of doctors who campaigned for repeal as part of Cork Doctors Together for Yes. And repeal passed, but I suppose we knew really that the next phase of the work was only beginning. And so START was founded, and it was originally a group of GPs and some secondary care doctors, largely from Cork, who were, I suppose, really, really motivated to ensure that whatever system of abortion care came into Ireland would be woman-centred, but would also work within our health system. And it's really in no small part due to the doctors who advocated and spearheaded as part of START that we have a GP-led early medical abortion care service and not dedicated abortion care clinics like we have in lots of other jurisdictions in countries near us. And I won't name all of those people individually in case I forget anybody, but their leadership was phenomenal, and we really owe them a very great debt because they not only envisioned how a GP-led early medical abortion service might work within Irish general practice, but they also, in a really short space of time, developed and rolled out education for GPs so that they would be able to set up a service and get going on the 1st of January 2019. And that was the Minister's mandate at the time. And it was really, it was an exceptionally tight time frame to do this. And they did it so well, and they continue to be really central in providing support and education to GP providers. And I suppose what Laura has found and what we've all found over time is that the START group has evolved and has grown. And it has grown hugely, and it has loads of members all over the country now. And we have on several occasions thought, well, given that START begins with the word Southern, because it was Munster-based, should we change the name? And it has come up on several occasions, but we've decided for now that the name will remain. And really the name remains because it is so synonymous with the support that it provides primarily through its WhatsApp group, which has over 600 members across the country at the moment. And the WhatsApp group provides a really timely support system for GP providers. It gives clinical support and non-clinical support in almost instantaneous. The group is really active every day. You'll have queries. It might be something as straightforward as how do I order low sensitivity pregnancy tests, or what's the phone number for my local hospital coordinator. But it also might be an anonymized case to say, am I okay to manage this lady myself, or should I refer on? And the other thing it does and offers to GPs is it really connects you with other local providers in the same region as you. And what that does is, you can ensure things like cross cover for holidays or sick leave so that women will get uninterrupted, timely access to care. And just to finish up with, I suppose if you are listening to this as a GP provider and you're not a member of START, we would love to have you. And if you ask a local colleague, the likelihood is that they are a member and they should be able to add you to the group. And we also welcome GPs who are considering setting up the service but aren't actually actively providing it yet.
Many thanks once again to Dr. Ciara McCarthy and Dr. Laura Cullen for taking the time to share their expertise in the fundamental aspects of EMA provision for GPs in Ireland. If you have any comments or feedback on today's show, or if you have any suggestions for future topics you'd like us to consider, then please do email us at podcast@icgp.ie. And that's it for today, and indeed that's it for this two-part series on EMA, which I hope you found of value to your practice. Thanks again so much for listening, and until next time, take care.